Having completed the joint ranges of motion, passive range of motions, the accessory motions, and the resisted muscle tests, we typically would move into the special tests. And the special tests around the shoulder are many, and they're broadly divided into three main and possibly a fourth category. The first category are modifications of movement patterns, so tests such as the locking position and the shoulder quadrant. There are then joint integrity tests assessing the stability of the glenohumeral joint. There are impingement tests of the subacromial space. And then there's the other tests, such as the labral test, the acromioclavicular joint, and bicipital tendinopathy. When we look at modifications of movement, the first one that we talk about is the locking position, with the arm held in slight medial rotation at the glenohumeral joint and slight horizontal extension, so the subject lying supine and the arm taken out towards abduction, with the elbow slightly behind the longitudinal axis of the body. We push further into abduction. Holding the arm in medial rotation, we see the greater tubercle engaging into the coracoacromial arch. This creates pressure on the subacromial structures and impingements. Any irritation or inflammation of those subacromial structures will often lead to pain in this position. It's called the locking position because as the greater tubercle is engaged in that coracoacromial arch, you cannot move out of that position unless you come back into slight adduction, then laterally rotate the glenohumeral joint, and then you'll be able to move through to full elevation. The quadrant is a continuation of this test. As we move from an abducted through to a fully flexed position, the greater tubercle will roll around the coracoacromial arch, and tension in the capsule will cause the arm to describe a specific movement pattern. This is a high stress test, and it will stress a number of structures: the capsule, the subacromial structures, and so on. Instability tests may include simple tests such as the anterior draw test, in which the clinician simply draws the humerus forward relative to the glenoid fossa to assess how much anterior translation there is. The anterior aspect of the shoulder is typically the most unstable aspect. The anterior and inferior aspects of the shoulder are typically the most unstable aspect, and damage to the anterior capsule, for example something like a Hill-Sachs lesion, as we can see here, would lead to an increased translation. An alternative to this is the fulcrum test, in which the subject lies supine. The clinician places one arm underneath the junction of the upper and middle thirds of the humerus, and that arm acts as a fulcrum point. Downward pressure is applied at the elbow, and what we see is the shoulder sublux anteriorly. Another instability test is the sulcus test. In this situation, the clinician, as we see here, creates a downward drag of the humerus itself, and we're looking for the development, for the appearance of a sulcus underneath the acromion process. Posterior instability is far less common, but there are a couple of tests that we can do to assess this. The first one is a posterior dislocation test or posterior subluxation test, in which the subject lies supine. The shoulder is flexed to 90 degrees and the elbow flexed to 90 degrees and held in internal rotation. An anteroposterior force is applied to the humerus, and we're feeling for a posterior subluxation down here at the head of the humerus. An alternative test is known as the jerk test, in which the subject is placed in a sitting position and the arm is abducted to 90 degrees. Again, a longitudinal pressure is applied to the humerus in a cephalad direction up towards the head. The arm is then moved forward towards horizontal flexion, and a positive test is when a sudden jump or a jerk is felt on the movement. This is indicative of posterior instability. Moving on to the subacromial impingement test. Test specifically for, or reportedly specifically for supraspinatus tendinopathy, is the empty tinny test. The subject is asked to place their arm midway between flexion and abduction, and the shoulder is held in medial rotation. The clinician then applies a downward pressure to the arm. So here we've got the clinician pushing down, and the subject then resists that movement. We're looking for pain in the subacromial space. Changes in scapular position, so often the subject will try to elevate their shoulder, and or weakness. It's reported as being diagnostic of supraspinatus tendinopathy, although more recently some articles have suggested that it's a non-specific test for subacromial impingement. Near impingement sign, as we see here on this top picture, is where the subject holds their arm flexed to 90 degrees, medially rotated to its limit. Keeping that arm in medial rotation, the arm is then taken up towards full flexion. Again, this is a non-specific test for the subacromial structures. Hawkins or Hawkins-Kennedy impingement test is where the arm is held, the glenohumeral joint is held at 90 degrees of glenohumeral joint flexion, and it is then forcibly internally rotated. Again, as we can see in this bottom diagram, we're looking for, once again, pain in the subacromial space and or weakness. These are tests, these are non-specific tests again for subacromial impingement. So it could be anything like supraspinatus tendinopathy, long head of biceps tendinopathy, and the subacromial bursitis. Test for infraspinatus. The infraspinatus muscle passes under the posterior acromial corner, and that can also become impinged. The client abducts the arm to 90 degrees, flexes forward or moves towards horizontal flexion slightly to approximately 45 degrees, and the arm is placed, the shoulder is placed in slight internal rotation. Resistance is then applied as the client tries to resist, tries to push into external rotation. Tension in infraspinatus will often stress the damaged site, and the subject will often experience pain. The drop arm test is a fairly simple test to perform. The client abducts the arm through to full elevation at 180 degrees. They lower their arm out to the side, and as they move through a painful arc, there is a sudden inhibition of surrounding musculature, and the arm drops. So there is an inability to control that lowering. This is as a result of neuromuscular inhibition. Again, this is indicative of subacromial impingement. It's a non-specific test for subacromial impingement structures. The biceps tendon passes up to the shoulder through the intertubercular sulcus. It then passes in between the coracoacromial arch and the head of the humerus before attaching onto the supraglenoid tubercle. To assess for the integrity of the bicipital tendon or irritation of its synovial sheath, the client's elbow is flexed to 90 degrees. The arm is slightly internally rotated. The subject pulls into further medial rotation whilst resisting elbow flexion and supination. Tension through the biceps tendon itself will often lead to discomfort and pain, and or weakness and neuromuscular inhibition. When assessing for the integrity of the acromioclavicular joint, the common test that is done is the scarf test, in which the subject is asked to move their arm across their body. Pressure is applied down at the distal end of the humerus into a horizontal flexion position. Pain at the acromioclavicular joint is often indicative of AC joint dysfunction. Disruption of the AC joint may present as a visible elevation of the lateral end of the clavicle, and dislocation of the AC joint is not uncommon. The glenoid labrum that sits around the edge of the glenoid fossa is a fibrocartilaginous structure, and this can tear. The common site of the tear is the superior part of the labrum itself towards the lateral end of it, so the thinnest portion. The tear is often in an antero-posterior direction, and these types of tears are known as SLAP lesions, superior lateral antero-posterior lesion of the labrum. There's a number of tests that are reported to be indicative or diagnostic of SLAP lesions. The first one is an anterior slide test, in which the individual resists the movement of extension, whilst applying anterior shearing motion to the glenohumeral joint. So here's the clinician producing an anterior shearing motion at the head of the humerus whilst resisting the movement of extension. And again, we're looking for pain, instability, and or crepitus. O'Brien's test is where we have the subject held with their arm in a flexed position, 90 degrees of flexion, immediately rotated, and the clinician then resists the movement of horizontal adduction or horizontal flexion. So in this case, the subject is pulling off towards their left-hand side whilst the movement is being resisted. Again, this creates compression of the glenoid labrum, and we're looking for pain and or crepitus. Final test here is the crank test. So in this case, the clinician will apply compressive loading along the line of the humerus, and they will passively medially and laterally rotate the humerus. And again, we're looking for crepitus. This has the effect of compressing the humeral head against the glenoid labrum, and if there is any tear there, as the humeral head rolls over the tear, we often see crepitus. Having performed our special test, we may go on to functional tests, movements such as reaching, putting our hand behind back or hand behind neck, gait, observing how the individual's gait may be modified as a result of glenohumeral joint action, the horse stance position, this one here, in which we look for stability and control of the glenohumeral joint. There's a number of functional tests that can be performed. Finally, we palpate. We palpate to confirm for suspected pathologies. The bony areas we may want to palpate will be the sternoclavicular joints, the first rib and costosternal junction, the clavicle as a whole, the coracoid process, the AC joint and the glenohumeral joint, and then most importantly the bicipital groove and other areas of the scapula. Specific muscles that may be presenting with pathology, the common ones that get irritated are the biceps brachii, long head, the subscapularis insertion, and supraspinatus. Less commonly deltoid and pectoralis major may also be injured. It's important to note that muscles such as sternocleidomastoid and the scalenes that are cervical muscles may also refer down to the glenohumeral joint. There are a number of other tests that can be performed at the shoulder. There's a whole raft of tests that can be performed at the shoulder. Some of the important ones include neurological testing, so assessing dermatomes and myotomes of the upper limb, and very importantly assessing the mobility of the nervous system via upper limb tension tests 1, 2 and 3, which assess the mobility of the median, radial and ulnar nerves respectively. It's not uncommon for patients to come in with significant pain, significant loss of range of movement at the shoulder as a result of a neurological pathology. Vascular testing is also important. The thoracic outlet refers to the upper rib, the first rib, and the relationship of that with the scalenes and the subclavian artery as it hoops up and over that first rib. Allen's test and Adson's test are two tests that assess the integrity of the upper limb vascular system. So in Allen's test, the glenohumeral joint is held abducted and laterally rotated, and in Adson's test, again, the glenohumeral joint is held in abduction and lateral rotation, but this time the elbow is extended and we take on ipsilateral cervical rotation, so we get the subject to turn and look towards their limb. The tension in the upper limb vascular supply may lead to occlusion of the artery, and we see a loss of a radial pulse. Having completed our assessment, it's important to get a clear understanding, clear analysis of our findings and creating a problem list. Each test we perform will invariably assess multiple structures, and so all of those structures should be considered. In planning our treatment, we must clearly identify short-term goals and long-term goals. Pain is usually a key feature of shoulder pathology, whereas instability and weakness is often one of our long-term goals. So the short-term goal may be to alleviate pain, to alleviate pressure. Long-term goals may be to correct instability and to correct the contribution of structures such as scapulothoracic movement and thoracic movement itself to glenohumeral joint function.